Okay, here we are.
Yeah, it
You're
says,
with me?
I'm with you. It says live on Facebook.
Trying to see where we are. Where is my, oh, there we are on Facebook. Okay. Well, anyway, I don't, this is my first time doing it through this channel, so we'll just go with it. All right, well, I'm here with Dr. Matthew Albert, surgeon here locally at Advent Health, and just wanted to ask him a few questions. He was nice enough to come on with me here and discuss kind of a few things and what's going on in our industry. So let's go ahead and ask him a few questions. So, Doctor, what are your thoughts regarding all of the different scientific advice we are receiving in the news?
Yeah, it's a phenomenally interesting, thing. And as you see, the normal person sitting at home, one out of boredom, but more likely out of fear, anxiety, wants to know everything they can possibly know about this. I didn't want to get into specifics. I'm a colon cancer specialist and colorectal surgeon, but we have the ability to interpret some of this a lot differently than the normal person. And I've seen this be a real common topic on people fighting each other on Facebook about what's correct, what they just recently heard, counter, and even you see on the news feeds, multiple. Contradictions, even, from the president to his health advisor 12 seconds later. People have to remember how this data actually gets to us. It comes from doctors who are on the front lines, fighting this, not some news reporter on the side who's tallying up, deaths for each hospital. And so the science of science has been disrupted massively in this as well. Much like patients, as physicians too, we want to know what treatments work, what treatments don't work, what are the risk factors for these bad outcomes that you see, and who's susceptible to dying is really what's on everybody's mind. Is why you saw the first information out was really going, who are the people dying in China? And we quickly said, well, it's the patients who smoke, those who have diabetes, the elderly, those risk factors, But what else? And how do we find out these things? And the more important thing is, what medications are working and what medications aren't working.
Yeah, you
So
hear about the ibuprofen thing.
exactly. So just for a small exercise, I'll take you through one of the most common things that we've seen, the use of chloroquine. All right. So chloroquine hasn't been used even for malaria for a good bit of time because there's toxicity and there's side effects to these things. So what everybody in the world has chloroquine on their Facebook now is only for one reason, because in France, they found 40 patients that they used chloroquine azithromycin on, and then subsequently wrote up their findings with this that were extraordinary. All right. But with all data and with all science, the next thing we do as physicians are we say, well, is that data real or is it total BS? All right. And so, for the first part of any study to happen, even if I say, hey, this is great, I want to write a paper tomorrow, I have to consult my local IRB. It's an internal review board. It's for ethical it's for the safety of patients that, in the study, their identities and their privacy is being maintained. So this costs usually a couple $1,000s. They meet once every few weeks. It takes sometimes months for you to get an IRB. So how suddenly are there scientific papers out there? In fact, this one specifically, that data was actually published in the Lancet, very high-powered journal. And when you look at that, it was a 14-day trial of which they got ethical support for this on day X. And 12 days later, they were concluding the trial, which you say, How did the 14 days fit within that? And people instantly go, well, they were enrolling patients before they actually had approval to. And that's just one little detail of it. The second part of it is that the goal of any study with medication, or see if these things work, is they have to be tested against controls, either another medicine or nothing else. And then we have to control for every single little variable there to see and make sure that we can show that effect. So in that study that everybody is now using this treatment over, the fact is that the patients who received chloroquine only were in a totally separate institution. They did this in 3 different institutions. So when we talk about confounding variables, how do you know at that institution that had these great results with chloroquine, it wasn't because they used all the most experienced doctors, or their algorithms for all this treatment was much better, or they had much better practice in this, or they were using one of 30 other different medications in there. And so data is validated, it goes rigorous statistical analysis, and it undergoes peer review. And so for real data to come out of this, it will take months and months. And in the next year, you'll see a few thousand articles come out. And even then, you won't be able to really know for sure about a lot of these things because they'll be retrospective. We'll be looking back at this collected data. And retrospective studies have a really difficult time of controlling those variables. They don't know what was happening in those hospitals at that time, other than just getting the medication, that was given. And so the real evidence that we have on all these different treatments that the scientific community would say was valid is that, 0. So a lot of this information is going straight to non-peer-reviewed scientific publication. In general, in non-war times, that it would be an outrage. It's why the entire FDA was created and everything else. So treatments get fully validated. We know that they work and we know that they're safe before we unleash them on the public.
So the information that keeps getting leaked is just kind of people
And
finding.
so we're seeing this in just real time, which, we don't have the capabilities to collate and manage data like we would like. In addition, it's not just real time, it's chaos. It's the scientists on the side who are doing this data. Unlike now, it's not the ICU guy who goes home and says, let's just see what happened for the day and see what worked and what didn't work. And so, the fact is, it's why you see these huge discrepancies over ibuprofen and whether this is you shouldn't take or should. Now, this is an over-counter medicine, so it has real implications because everybody has this on their shelves. And so that has been dealing with the fact that ibuprofen potentially can upregulate some enzymes in a specific population that make you more susceptible to the virus. The other thing about the data that comes out and with all science is it generalizable? Just because they had this in one hospital in France, does that mean everywhere in the world will have the exact same outcomes of it? And the fact is, we know that patients are all uniquely different, that populations and their unique genetic imprints of every unique ethnicity, that we know some of them are more susceptible to certain diseases, to certain antibiotics. And it's just impossible to really get the information that people want right away. That being said, chloroquine, based off that one study, is being treated on nearly every protocol that we see in the United States. These things are all rapidly being shared in physician groups. If the normal public got on some of these sites, the flood of information coming through there is just astounding. But chloroquine's almost nearly on every single protocol because we don't have anything else really to use. It gives us some hope. But even these suggestions, people don't realize the mass downstream effect. It's interesting. I mean, chloroquine causes prolongation of, it can change the electronic circuitry of the heart. And people can have sudden arrhythmias and death, from it. And so how do we monitor that when we say that these are protocols that are happening and updated differently at all institutions, what we're following? Should they get echoes every day? Should they get EKGs every day? If they get EKGs every day, they need a technician to come in the room, do the EKG, use PPE, protective equipment that's now getting wasted. And so every one of these little things has a particular challenge around it. And
Yeah,
it's happening
you hear a
in
lot
real
like,
time.
do you wear the gloves? Do you not wear the gloves? Do you wear the mask? Do you not wear the mask? And a lot of this stuff, you read different articles, different news channels, and you don't know what's fact or what's fiction.
It's confusing, and because there is no scientific fact at this point. It's correlation of best evidence by best disease experts doing their best, and which would satisfy no one in any other part of time. You think back to HIV, it wasn't 3 weeks that we knew anything about this whatsoever. It was a decade,
That was a long
later
time.
of this new virus. So nobody's had this virus, nobody's treated this virus. It's all new. I mean, we're correlating lung disease and treating patients that have similar lung disease from other trauma and infections and everything else. But even that, a lot of scientists are saying, don't treat them like that on the vent. These patients are different. They require a little different management strategy. So you're going to see huge variations in outcomes likely based on capabilities of hospitals, based on protocols, based on care delivered, based on how, crashing some systems are or not. But yeah, that's the hard thing for the public. Even for me, I walked through my hospital today. 50% of the people I walked by were wearing masks. And I said, okay, help me out here. Last week, you told me promptly to take off that mask. I got a video memo, the whole hospital from the infection control saying masks aren't needed. And now you're seeing even this little different shift on a national level from the president, from Fauci, and even from, these local recommendations are changing by the second. They leave even doctors anxious about what's the next step. What do we do? How do we recommend other people? It's controlled chaos as
So
best it can
it's
be.
definitely, I mean, as a surgeon, obviously I got to imagine you've been affected a little bit by this.
Yeah, I mean, it's interesting because we're all a little bit in different boats. Certainly one would say, well, geez, the gynecologist. We need as much medical personnel as possible, but can the gynecologist, help out in this? First of all, our profession as a whole, and as in surgery, we've shut down surgery, actually weeks ago in preparation for this. It's really twofold. One is making sure that patients, nurses, doctors aren't put at unnecessary exposure and risk. Secondly, so we have the capacity and room. We can't have patients sitting there who have unpredictable post-operative courses taking up beds that may be needed. The other major reason is so you don't go through PPEs in a normal operation. There's 4 people gloved and gowned. We may need that for other times. So the surgery business in general has taken a huge hit. You think about what we do, specialize in cancer surgery. That's even a bigger dilemma, which every day there's newer and changing recommendations from the equipment we use. Actually, minimally invasive surgery, because it puts gas in one's abdomen and potentially dispenses infected, vaporized tissue and smoke around the operating room, that some surgeons have actually stopped doing minimally invasive surgery. We have memos from the American College of Surgery and our Surgical Endoscopy Society, who has raised these similar things. But then you imagine for patients and for us too, the dilemma with cancer patients who are more vulnerable, have anxiety and other issues on their plate. They're sitting at home being told they can't have surgery, but worrying about their families, worrying about all the same things we are, but on top of it going, and I have a cancer growing inside me. So we continue to do cancer surgery, although now even those guidelines continue to be updated. Early cancers, or some of these are left at our discretion, and now you have basically an entire committees being formed to deem which surgeries are necessary and which aren't, because they take that out of our hands and they don't trust us. We'll often say everything's an emergency to take care of somebody.
Wow.
But, early cancers can wait a good while longer. We're changing the way in which we sometimes even treat them. For instance, many patients who may be getting surgery right up the front, we may go, let's give them the chemotherapy and radiation will be good for them. It's not unreasonable treatment and it can delay their need to be in the hospital for surgery. From another standpoint, though, it gets to us as individuals too. We've always
Yeah, I was going to say personally, I mean, it's got to be hard on these doctors seeing what's going on.
yeah, we've always been able to be easily manipulated by insurance companies, by the population at large, by by health grades, by every internet site, by everybody because of the profession and the oath with which we took to to humanity. They know no matter what happens, no matter what they do to us, that we'll be there, no matter what, we'll be there to take care of the patients. No doctor will spite a patient to, get back at an administrator. It just doesn't happen, but we're vulnerable. And right now, so for my instance, you say, geez, you're probably sitting there, you don't have to do surgery anymore. What the heck are you doing like everybody else? Well, unfortunately, as you see the call out in New York and other places, is with the degree and numbers of doctors and healthcare providers getting infected, there's a real crisis of healthcare shortages. So even though I'm a colorectal specialist, our patients get real sick. We learn trauma surgery. We take care of critically ill patients when surgery doesn't go just right. So I've had more than a year and a half of critical care experience. And I volunteered at my hospital to be that critical care doctor now and jump in on the front lines. For my, I have huge.
Definitely, you guys have become definitely superheroes because I don't know what the world would do without the staff and everybody over there doing what they're doing.
I mean, it's a real moral dilemma for me. I have a family that I need to take care of and protect as well, but I have a profession and a skill that I need to uphold, and that I have the potential to help people right now. I actually had a discussion with my family about going to New York and help out. I have friends in Mount Sinai, I have friends in Cornell and Memorial Sloan Kettering, at every single hospital in New York City. I have friends and healthcare providers there that already are infected and are at home with this. Yet at the same time, it'd be easy to say, I want to be safe and be protected and be able to take care of people later.
Yeah, how do you leave the how do you protect yourself and your family? I've talked to folks that know doctors or have friends and family that are bringing 3 and 4 change of clothes with them, taking showers out back, doing certain things, trying to be protective of their family.
I think that's been a huge thing. In addition to what I was saying, the moral dilemma of then coming home and exposing your family. As I mentioned to you before, for me, the hardest thing would to be have on my conscience for a long time that I was sitting at home, while my colleagues and friends and were risking their lives. I mean, the fact is that some of us will die. Some of the friends that I know who volunteer themselves will die, doing that in the line of duty. I mean, it's as scary as you can think. But I really have started to take some precautions. I came in from surgery today. The majority of us laugh about us changing in our garage and going through all these ridiculous rituals. I think that New York has really stood up. Look, there's thousands of hotel rooms, that are unoccupied. You saw yesterday on Facebook, the Four Seasons, even in New York City, is offered. And so I hope here that follows suit if we need it. There's no question. I already told my family that I won't be coming home, that I'll stay in a hotel if I'm going in taking care of ICU patients every day. My friend in Italy, Antonino Spinelli, great guy. He did a huge broadcast in the European Society. Because they hit first there, he had the experience. He's been on phone calls with all of us in the United States as individuals, as institutions, giving updated information, protocols, how to fight this. He hadn't seen his family in 3.5 weeks now. They're quarantined
Wow.
separately. He's quarantined, and it's a phenomenally challenging time. Don't kid. I'm scared to death, about it. People would go, I take plenty of risk. I go, jump out of, if someone told me to jump out of a plane, sure, that sounds like fun. A lot of things we do, have small risk, and probably this in the big scheme of things, we don't know the mortality of it because we don't know the number of population actually infected with it. You keep hearing this on the news, but it's probably akin to getting, bit by a shark, something along with those statistics. At the same time, no, I'd still rather go, surfing and take my chances getting bit by a shark
For sure.
than this. Don't kid. It crosses my mind every second. It will every second I go in there, every patient I take care of. One thing recently that was posted that I think is a huge, huge, huge memo for healthcare providers is there are no emergencies in a pandemic. All right. We're used to jumping into action the second we see something bad. You may have a patient in cardiac arrest where we know seconds count. But the fact is that you can't go in there without PPE. You need to take the time to don the appropriate garb and mask and everything else and protect yourself and protect others. We have to be so careful at not exposing ourselves and worsening this, exposing others during it. But it's a great point. There just are no emergencies during this. You can't go flying into things and unprotected.
Yeah. So I know the big question, I know, um, thanks for doing this with me, but, is Central Florida ready for COVID-19 if there is a huge surge?
So I can say, safely, look, everybody makes different preparations. As we talked about before too, there is no life experience for this. We haven't been sitting there in boot camp and at Fort Collins or Fort Bragg for the last 6 months, doing everything possible, simulation training, this and that. Because of the variabilities and the unknown, how many, how severe, all these things. I think we're amazingly fortunate here in Central Florida. We all have had personal, issues over our time and within our profession with administrators, with insurance, this or that. I can say honestly that we've had a lot of communication, that our hospital administration has done an amazing amount of work. I haven't had a mask ripped off my face by an administrator anywhere. We've received nothing but support, encouragement, and preparation. So the real thing is, though, is are we ready? I don't think anything can prepare you for this. Now, we're not 8.5 million people like New York City. We're much smaller. I think we started our social distancing and protocols a lot earlier. So we shouldn't see the numbers, which they have. But like everywhere, they continue to escalate and go up every single day. But the other thing we've been blessed with, and our hospital system is one of the wealthiest in the country. So resources wise, we've never been really short on things like that. But what you hear going on is actually, true, that everybody's fighting for the same resources. And it's not just politicians and governors and FEMA and others, but it's actually independent contractors who said, shit, I'm out of work right now. But if I get some gear, I can make a fast buck selling it on to hospitals. So they're diluting that pool greatly too. We certainly haven't seen anything close to running out of PPE or other stuff. We're amazingly, if you see our hospitals are even somewhat empty right now, it's because our surgical floors are all empty. The surgery floors are often what makes the hospital run financially. But our floors are empty right now in preparation. So the good thing is, because when you're running at 90% capacity like we always do here, even getting a bed on a normal day, a patient needs ICU care. Sometimes flipping patients around to get that patient the right bed at the right time is tricky. You can't do that with a hospital that's 90% full. And so we've had to, clear out a significant patient volume. There's a minimal of patients in the hospital who need it. And so otherwise, we certainly are prepared from a space capacity, but I don't think anything prepares you for the emotional, physical toll capacity.
That's coming.
Yeah.
Yeah. And well, again, I mean, I appreciate you coming on and talking about this with me, and I hope I can definitely have you on again in the coming weeks, and kind of hopefully we're moving in the right direction. I don't know what's going to happen in the next 2 weeks with the social distancing. Seems like people aren't staying home like they should. So I think we may unfortunately see a growth in this.
Yeah, well, unfortunately, it's safe to say that it won't just be ever declared, a national end of COVID day, and we abruptly, go back to normal life. It just won't happen. And already you'll see the implications of this in our everyday life. My friend just keeps on. He goes, if I see that word, the new normal again, I'm going to lose my normal. But you're going to see, real shifts in how we do things. No question. Even once we start going back into things, much like Hong Kong, China, and everything else, you're going to see little pockets of outbreaks, all over the place. Hopefully, though, by that point, it won't be in the demand phase of this where it overwhelms any system. We'll have experience how to quickly shut it down. Hopefully testing in these things months down the road, we'll be able to we'll have systems in place. Whereas right now we're designing the systems on the go, and we haven't had time you don't have time to rethink everything until afterwards, where you could say, hey, what went good and what didn't go good. So things will always be different. I think that, that guy, even that partner coming into work, with the man flu, where he used to be congratulated, that he's going to be promptly given a one-way ticket back home. There's going to be, no congratulations for working through illness and contributing and being part of the team. It's going to be, go home, get out of here.
Even now, a cold, you used to go to work. Okay, if I have the flu, I'm staying home. But if I got a head cold, I can do it. But now, if you're coughing and sneezing at work, people are gonna be like, hey. And I mean, I kind of remember the whole HIV thing too. I mean, I was, much younger. However, it was like, I'm not gonna kiss anybody. I'm not gonna do this.
Yeah.
I'm not gonna do that. And over time, we've realized that, look, you can pretty much do just about anything, and you're going to be okay. So, hopefully, God willing, in time, it's, you've got the coronavirus and it's a shot in the arm, and rest for a week and you're back up and running, God willing. So,
yeah, I think, my other curious thing is, it's how doctors, what's going to happen to the health profession in general after this. As I've said, you've seen the system bending for a long time. Physicians, healthcare workers upset. On a national level, our healthcare system is debated every day in the presidential race coming up. Individually as workers, we keep getting called we're superheroes, and we're like, soldiers going into battle. And I actually started really thinking and contemplating, what does this look like afterwards, all this?
yeah.
As I said, are we going to come home from battle then and have a one national doctor's day that everybody celebrates and get some crappy government insurance and be ignored for the rest of the time?
Yeah,
Or,
hopefully not, right?
on the other hand, I think that you're going to see a collective voice in medicine by doctors, nurses, and healthcare providers, unlike you've ever seen before. I
don't mean to, I got 13 seconds before this stops on my recording here. So I appreciate you. And thanks for
Cool.
coming on with me. And
Yeah,
I
no,
stopped that part of
absolutely.
it, but we can continue to talk if you'd like.
You
But I
know,
had on the podcast, for some reason, it only gives me 30 minutes. So I just kind of had to shut that part
yeah,
down,
no
but
problem. I'm happy to do this anytime, like you said, for
sure.
your own experience. We're always doing more and more public speaking, talking. There's lots of skills you can enhance in your downtime.
Yeah, just
With
for
it. But
me,
but no,
myself.
on that last thing, I really wonder. I think this will be the breaking point for a collective voice of physicians. I think you may even see attempts at unions and things like this to really band together and say, we're not doing this again. We're not going to be pushed around by administrators and who sit there in the ivory tower and throw us into battle while we, it showed the president of Mount Sinai Hospital and one of the CEOs of Mount Sinai Hospital are currently in West Palm Beach in their mansions. They make upwards of $12 million a year. Now it's been talked about. Look, they're old, they're elderly, they're probably in careers. I'm sure they're on email every single day. But the fact is, the optics look bad. When the
Very bad.
when the general is sitting back at home in his tent and his soldiers are out getting clobbered on on the front lines. I mean, sure, there's some communication, but yeah, not good optics. And I think you'll see it reach a breaking point. Whether we really can affect change through this, I'm not sure. But
I hope
it's an
so.
interesting time for the profession.
Well, maybe we'll catch up next week and see kind of what's going on next, or maybe in 2 weeks I can catch up with
Yeah. Yeah, if I
you.
listen, if I am secluded in a hotel room and doing hanging out and going into the ICU, and we get a real surge where we are, that I have no problem. I'm sure I'll have more than enough boredom to sit at night and need some therapeutic talks. Uh,
Yeah.
you
Well,
know,
shoot me a text.
yeah, I'll plug in anytime with you and give you updated live version. It gets even with that. You've had institutions clamp down on physicians and nurses discussing the current scenarios within that hospital, whether they're out of supplies or we're getting treated poorly. That they've been effectively censored and shut down. So like I said, I have no problem be like reporting from the front lines, like Tom Brokaw with missiles
Yeah.
flying behind him.
Yeah. I don't mind. I mean, listen, if you think you want to talk or you want to get on, definitely hit me up and I'll jump on with you. We can bring some information to the public and see what's going on and definitely help you get through this.
All right, cool. Well, I hope that gives some people a little different perspective from our standpoint. What actually is happening. So,
Yeah,
uh,
I'm sure you have. Well, you have a great day. And again, we appreciate what you're doing.
cool. Take it easy, man. Take care.
Bye.